Stanford University, and I'll be speaking to you today about nasopharynx, anatomy, and pathology. I have no disclosures. We'll briefly review the anatomy of the nasopharynx, discuss pathologies that can affect this region, and talk about some potential pitfalls. The nasopharynx is the uppermost aspect of the upper aero-digestive tract, shown here by this yellow star. It is located posterior to the nasal cavity and separated from it by the posterior choana. It is located superior to the soft palate. The nasopharynx is part of the pharyngeal mucosal space. Hence, it contains squamous epithelium, lymphoid tissue, minor salivary glands, and constrictor muscles, and these tissues give rise to the common pathologies of the region. The nasopharynx does have somewhat complex boundaries. Superiorly, it is associated with the skull base and the craniovertebral junction. Here we see the sphenoid sinus, as well as the sella turcica. Laterally, it is associated with the parapharyngeal space, this fat-filled space that we see lateral to the nasopharynx. And in the axial plane, we appreciate this rather complex anatomy of the eustachian tube orifice, torus tubarius, and fossa of Rosenmuller, a place where small nasopharyngeal cancers can hide. The nasopharynx is also in close proximity to cranial nerves, to blood vessels, such as the right and left internal carotid artery, and also brain tissue. You see how close the nasopharynx is to the brainstem and upper cervical spinal cord. The nasopharynx looks different in children versus adults. Children typically have prominent reactive adenoidal tissue that is very symmetrical, that fills the nasopharynx, and is often associated with reactive retropharyngeal lymph nodes. In adult patients, nasopharyngeal lymphoid tissue is typically minimal after the age of 30 or so, unless the patient has an upper respiratory tract infection, sinusitis, or HIV. In the axial T1, T2, and post-gadolinium images, we appreciate the smooth surface of the nasopharynx, this thin mucosal line, which is mildly hyperintense on T2 and enhances moderately, intensely, and homogeneously post-gadolinium. Why so much emphasis on the nasopharynx? It's included on every brain imaging study, as well as every study of the head and neck, and often cervical spine and full spine studies as well. So that gives us the opportunity to make incidental pickups or important pickups, as well as, unfortunately, the opportunity to overlook things. So here's a typical cautionary tale in a 47-year-old man sent to evaluate for sinusitis. He does have some mucosal disease in his right sphenoid sinus, but he also has sclerosis of his right pterygoid body, some erosion of the floor of the sphenoid sinus, and a soft tissue mass in the right nasopharynx as compared with the normal appearing left side. 1 year later, he gets an MRI for right oral fullness. At this point, he has a nasopharyngeal mass on exam, both physical exam and MRI. We see this large lesion of the nasopharynx associated with a mastoid effusion, and unfortunately, this patient was diagnosed with nasopharyngeal carcinoma of the non-keratinizing undifferentiated subtype that is typically associated with the Epstein-Barr virus. The differential diagnosis of nasopharyngeal pathology is broad. We can see congenital abnormalities, infectious inflammatory processes, benign and malignant neoplasms, as well as a whole host of miscellaneous entities, but we'll only have time to review a few of these today. This is a classic Tornwald cyst, a remnant of the notochord that is located superficial to the superior constrictor muscle and covered by the mucous membrane of the nasopharynx. Tornwald cysts are typically T1 bright because of increased protein content. Another lesion that we commonly see in the nasopharynx is the mucus retention cyst. These are also submucosal masses, but they are typically located off midline and have this characteristic light bulb shape that we see so clearly on a T2-weighted MRI. Adenoidal hypertrophy, we mentioned, is common in children, but we also can see it in adults, especially an adult like this patient who happens to be HIV positive. This patient was referred for CT and MRI for neck pain and headache. On the scout view for the CT, we see this prominent soft tissue abnormality at the level of the nasopharynx. But on the axial image, we see that this tissue is very symmetrical, homogeneous, and has a really striated appearance. On our sagittal T1 MRI, we see that the skull base, the clivus, the craniovertebral junction is completely normal in its appearance, except that the marrow is mildly hypointense, as we commonly see in HIV-positive patients. And on the axial T2, the lymphoid tissue is homogeneous. Again, it has this rather striated appearance and these small internal cysts. And these findings of stripes and striations, symmetry, homogeneity, and small cysts are consistent with adenoidal hypertrophy. Now, sometimes it can be a little hard to decide whether you're dealing with adenoidal hypertrophy or a nasopharyngeal tumor, and asymmetry and nodes can be really helpful. So here's a 54-year-old undergoing an MR of the brain for headache and neck pain. In his axial T2, we see a right nasopharyngeal mass expanding the fossa of Rosenmuller, clearly asymmetrical compared to the other side, and with a pathologically enlarged heterogeneous lymph node. And this patient was ultimately diagnosed with nasopharyngeal carcinoma. These two patients, on the other hand, have lymphoid hypertrophy. The soft tissue of the nasopharynx is symmetrical, striated, shows some small internal cysts. There are no associated abnormally enlarged lymph nodes. But remember, when you're in doubt, clinical correlation and tissue sampling as appropriate can be very useful. Another consideration at the level of the nasopharynx is this patient's diagnosis. This is a 78-year-old man with right ear pain and headache. He has asymmetry of the right nasopharynx as compared to the normal left side. This abnormal soft tissue extends laterally to involve the parapharyngeal fat and also posterolaterally into the carotid space. There's erosion of the right occipital condyle and the clivus. This patient went on to an MRI. We can see abnormal soft tissue on the T1 weighted image, replacing fat in the parapharyngeal space, extending to the carotid space, the prevertebral muscle, the occipital condyle, and also skull base foramina. On the axial T2, we see that this process is very diffuse, mildly hyperintense, and associated with a mastoid effusion. Following GAD, there's diffuse enhancement of the soft tissue without a discrete mass. And this is a characteristic imaging appearance of skull base osteomyelitis. In this case, the patient was diagnosed with Pseudomonas aeruginosa, which is the common organism associated with skull base osteo, and he also received a new diagnosis of diabetes mellitus. Now, skull base osteo is often associated with external otitis, malignant external otitis, but in this particular case, the ear canal was uninvolved. So we do not always see involvement of the external auditory canal, and not seeing that should not dissuade you from the diagnosis of skull base osteo. Let's move on now and talk about nasopharyngeal carcinoma. This is a cancer with a distinct epidemiology and histology that is a common form of cancer in southern China and Southeast Asia. The non-keratinizing undifferentiated subtype is consistently associated with the Epstein-Barr virus, as mentioned. Clinically, these patients may present with neck mass. This patient has bulky adenopathy. They may have nasal obstruction or bleeding. They may have hearing loss, otitis, or otalgia because of eustachian tube dysfunction and mastoid effusion, middle ear involvement, as seen in this patient. Sometimes the tumor will extend along cranial nerves. You see in this case growth to the pterygopalatine fossa, involvement of V2 in foramen rotundum. This tumor also extended superolaterally and jumped on V3 and extended up through foramen ovale. So cranial nerve palsies are also often seen with nasopharyngeal carcinoma. With regard to the tumor categorization of nasopharyngeal carcinoma, we use the AJCC 8th edition. T1 tumors are confined to the nasopharynx. Here we see a soft tissue mass with no parapharyngeal extension, no prevertebral muscle involvement, and the middle layer of deep cervical fascia appears intact. This is a T1 tumor. T2 tumors can have parapharyngeal extension or prevertebral muscle involvement. Here we see obvious parapharyngeal extension, loss of the fat on the left as compared to these beautiful fat planes on the right. We also see involvement of the left prevertebral muscle as compared to the right. T3 usually is given because of skull base involvement, and here we have a patient with nasopharynx cancer with clival and petrous apex involvement. T4 tumors are typically large and bulky. They may extend to the hypopharynx or the parotid, but most of the time, patients get to be T4 because of intracranial extension. Big, bulky tumor, lots of skull base involvement, but here we have involvement of the retroclival dura, the sella and suprasellar structures, extension to the hypothalamus. This is T4 disease. Now, all of these patients are treated with radiation. They may also get chemo, and following this, the tumor mass should decrease, but the nasopharynx may still be very abnormal, early on with edema and mucositis, later with fibrosis and scarring. At baseline, here's a patient with a bulky nasopharyngeal tumor. Early post-radiation, we have this fairly symmetrical, bright enhancement consistent with mucositis. And 15 years later, we have the so-called featureless appearance with effacement of the eustachian tube orifice and torus tubarius. And that is characteristic of late-stage post-radiated nasopharynx. Now, soft tissue abnormalities may persist in soft tissue and marrow, but if it's stable, it's usually granulation tissue and fibrosis, and that's good. If things progress over time, we have to worry about recurrence, but we may also be dealing with radiation necrosis or infection, and we always want to pay attention to vessels in follow-up, and I'll show you why. Here are some treatment-related complications: bilateral temporal lobe radiation necrosis, osteoradionecrosis of the craniovertebral junction, or the clivus, showing these little bits of air on the CT. Here's a critical stenosis in a patient with accelerated atherosclerosis, and here's an ICA pseudoaneurysm that resulted in life-ending epistaxis in this patient. This is a patient with a large radiation-induced fibrosarcoma. Now, recurrence is not uncommon and can be subtle. Here's a patient with a large primary tumor, bulky adenopathy, extensive disease on PET. After induction chemo, he's looking somewhat better, and after consolidative chemoradiation therapy, the patient is looking much better. Here's another image from that baseline exam. A few months later, the patient is interpreted as no evidence of disease, but this subtle recurrence in the nasolacrimal system was not identified. 4 months later, he's more symptomatic. Now he's got an obvious mass and the diagnosis is made. But in retrospect, on this earlier study, the ADC in particular really highlights this early recurrence. And so DWI and ADC may help you with some of these difficult cases. Now, NPC is not the only cancer of the nasopharynx. Here's a patient with a nasopharyngeal mass, pterygopalatine fossa extension, V3 involvement, orbital apex, cavernous sinus. This is adenoid cystic carcinoma that loves to jump on cranial nerves. Here's a patient with chronic eustachian tube dysfunction, a bulky mass of the nasopharynx with parapharyngeal extension, and this was mucosal melanoma. Oh, I should add, benign tumors of the nasopharynx are rare, like schwannomas and pleomorphic adenomas, and that's one of the reasons we're really focusing on malignancies. Here's an older gentleman with a nasopharynx mass, mastoid effusion, cervical lymphadenopathy, but look how very homogeneous this tissue is. It's FDG avid. This is lymphoma. If we were to look at this patient's ADC map, or in particular ADC values, these have been shown to sometimes be useful in determining lymphoma versus NPC, but most of the time, an FNA does the trick. Now, I don't really have time to talk about pediatric considerations. We know that adenoidal hypertrophy is common, but we also always want to think about rhabdomyosarcoma, as in this child, or NPC can also occur in children. With that, I am out of time. I thank you so much for your attention.
Hi, I'm Larry Ginsberg, and I'm grateful to Dr. Kennedy for allowing me to participate in today's program. I'll be talking about oropharyngeal cancer imaging and what can I do in 15 minutes? Well, I'd like to talk about HPV, an anatomy review and some basics of imaging, the importance of staging, and then lots of cases. So typical cases, cases of upstaging, the problem of the T0 N positive presentation, utility of PET, and then finally prognosis and adverse circumstances. So HPV is known to be the most commonly sexually transmitted virus in the United States and around the world, contracted by well over 50% of sexually active people and probably higher in women, and results in a great deal of human suffering. Most recently, data suggesting about 20,000 HPV-associated oropharyngeal cancers in men and 3,500 in women, and this represents 70, or at my hospital, at least 80% of all oropharyngeal cancers. And this incidence is increasing. Subtypes 16 and 18 are mostly responsible. And the demographics is different than the old days. So mostly younger or middle-aged white men, higher socioeconomic status, largely non-smokers and non-drinkers, but people that have had a large number of oral sex partners in their lives. And this cancer usually affects the tonsil, tongue base, and glossopharyngeal sulcus more than the other oropharyngeal sites. This just shows that while other HPV-associated cancers of other locations are stable in incidence, oropharyngeal cancer is clearly rising. Now, the subsites of the oropharynx include the soft palate and uvula, the palatoglossal and pharyngeal arches and tonsils, and the posterior one-third of the tongue or tongue base, as well as the posterior pharyngeal wall and pharyngeal wall inferior to the tonsils. This just demonstrates my relatively normal appearing oropharyngeal mucosa as of 2002, including my tongue base, vallecula, and median glossoepiglottic fold. So I believe that staging is very important. It provides critical data, prognosis, treatment options, protocol eligibility, and research on outcomes all hinges directly on the stage of the cancer, and it's really why they image the patient. So you are ideally providing the relevant information anyway, so my proposal is why not understand the criteria, specifically seek these relevant items and address them in your report and give them a complete product. And if you know the stage because you've been reading with that in mind, give them what they want, and your relationship with your clinicians will be much better. Regardless of HPV or P16 status, T1 through 3 is based on size, 2 or less, 2 to 4 centimeters and greater than 4 centimeters. And T4 status generally indicates some type of deeper invasion, but depends on the P16 status. Now, we now use AJCC8 for several years. It's similar to AJCC7 if the P16 or HPV status is negative, but if the P16 status is positive, then the primary and nodal staging is different. Bear in mind that regardless of P16 status, extension from the tongue base onto the lingual surface of the epiglottis is an upstage to T3 regardless of size. So if the cancer is HPV or P16 positive, T4 is not broken up into A or B, but rather some locally advanced disease if there's tumor involvement of the larynx, extrinsic tongue musculature. Those are the sites that are most commonly trigger a T4 staging, then that would apply. The nodal staging is different than for oral cavity or P16 negative cancers in that multiple ipsilateral nodes are still considered N1. And if you have contralateral or bilateral, it's N2. And then per usual, greater than 6 centimeters is N3. I'm not going to talk too much about the divisions here, but for HPV negative cancers, the staging is similar to the previous category, the previous staging criteria, in that there is a T4A and a T4B depending on the degree of deep extension. So some basics of oropharyngeal imaging. What is my modality preference? CT. Why? The reason is that I can get a good quality study if it's done right. Although there are technique matters that need to be adhered to, you can get a reliably good quality study that can be compared with a post-treatment patient who might be uncomfortable and moving or swallowing. So that's why I prefer CT, and I believe most centers do. There's no reason to do a post-contrast study. We only to do pre and post-contrast. We only do post-contrast CT imaging. On CT, oropharyngeal cancers usually have some degree of enhancement, sometimes a lot, but some degree of mass effect as well. Occasionally, the lesion doesn't enhance, or there's just mass effect, and some lesions, if they're very superficial, we may see nothing. On MRI, we do occasionally, some cases, they're T1 iso to hypointense, variably hyperintense on T2, and enhanced with gadolinium. And bear in mind that imaging is nonspecific. There's no way to differentiate squamous cell cancer from lymphoma or other lesions like salivary cancers. Illustrated here, a patient with a large oropharyngeal mass in the right tonsil and tongue base, and there's some lymphadenopathy with necrosis, so I call this an oropharyngeal cancer. Turned out to be lymphoma. The imaging is nonspecific. Just a couple cases of some soft palate lesions. This is a soft palate benign mixed tumor. Remember that there's salivary tissue in all of your mucosal surfaces, so a lesion needn't have to be squamous cell carcinoma. This happens to be an enhancing mass at the tip of the uvula and is a squamous cell carcinoma. This is a patient presenting with dysphagia, and it points out this was before the HPV era. It's an old scan, but we can see a pretty big tumor involving the soft palate. And remember, some patients will have synchronous malignancy. So this patient has a tumor along the posterior pharyngeal wall extending into the left piriform sinus. So synchronous malignancies do happen occasionally. This is a more typical tongue-based cancer. It's largely exophytic into the airway. It's bulky. It's asymmetric. This is a typical tongue-based cancer. This is a patient with a cancer in the glossopharyngeal sulcus. I didn't put an arrow on it because I want to see if you notice it, but it's very subtle. This is the lateral tongue base where it meets the pharyngeal wall, and that's the glossopharyngeal sulcus, and that's an important place to look. This is an example of somebody with a tongue-based cancer. It's very obvious, but because of invasion of the extrinsic tongue musculature, presuming P16 positivity, this would be a T4 malignancy by the AJCC8 criteria. This is a similar case of big tongue-based cancer, but we can see it growing into the area epiglottic fold. That's supraglottic laryngeal extension, and by virtue of that, this is a T4 cancer, assuming HPV or P16 positivity. And this is a patient with extension of a large, bulky nasopharyngeal cancer up into the nasopharynx. Now, if this was HPV negative, that would actually make it T4B. But the HPV positivity of this case, this is not an upstaging feature according to the present guidelines. So staging can sometimes be tricky. Just an example of a tongue-based cancer, a mostly exophytic tongue-based cancer. We can see it on CT, but this is the MR findings. T1 isointense, mild to moderate T2 hyperintensity, and not particularly striking, but perhaps some enhancement following gadolinium administration. I now just want to briefly mention the issue of the cystic nodal metastasis. This is a common presentation for HPV-associated oropharyngeal cancers, nodes that are all or mostly cystic, and for many years we've seen these things presenting and misdiagnosed radiologically as branchial cleft cysts. We still see several of these, and with an increasing number of HPV-related cancers, we are going to see more of these kinds of cases. So here's a patient with a cystic nodal metastasis, but the radiologist did not consider this tonsil cancer. This is a patient with a cystic nodal metastasis that was regarded as a branchial cleft cyst, but on the very same images, we can see the tongue base or glossopharyngeal sulcus cancer that was not called. There is a tendency for HPV cancers to present with a lower T stage but a higher N stage. Not every case, but many cases, they present with little or no clinical evidence of the primary, and they get worked up on the outside. And if nobody can find a cancer, they'll go to an ENT or a head and neck surgeon, and they'll do a CT scan. And if it remains T0, that is, no primary can be found, there is a role. It may be a little controversial, probably not anymore, but there is probably a role for PET CT, and I'm going to show a few cases in a moment. If after all the workup, they'll take the patient to the operating room and do an examination under anesthesia. And if there's no cancer found, then it's a carcinoma of unknown primary. But we will all be seeing a lot of these kinds of cases. Now, if the imaging is clear-cut evidence of the primary and they already know the histology from a neck node, then they may not need to do the examination under anesthesia. This is a patient who happens to be a radiologist, married for 20 years, presented with a right neck mass. We can see they're isodense, so they're tricky, but there's multiple right-sided nodal metastases, and it's HPV positive, but they couldn't see a primary. We did an MRI, we did a PET CT, and we couldn't really, maybe a little asymmetry. Anyway, they took him to the operating room. All these mucosal surfaces were negative, so this is a carcinoma of unknown primary. Now, why does that matter? If we never find a primary, then the patient needs radiation to all of the mucosal surfaces, and that can, but a lower dose. And so this can increase the toxicity, and it may not be a sufficiently lethal dose. Plus, they have to radiate both necks. If they find the primary, then they can radiate just the primary to a lethal dose of 70 gray. And this spares the other mucosal surfaces and possibly the contralateral neck. So here's a patient with an HPV positive cancer. They did a tonsillectomy elsewhere. They never found the cancer. What are the findings? Well, we can see that there's another nodal metastasis here, but it's HPV positive, so the neck staging remains N1. And then maybe there's a fullness down here. I'm not sure, maybe. So let's do a PET CT. The PET CT shows us that there is a hot finding here. They took the patient to the operating room and proved this to be the primary. Now, here's a couple cases where maybe PET helps, maybe it doesn't. This patient, all these patients now are clinically T0, no primary, and the CT did not show the primary. So there's nothing here on CT, a little bit of asymmetry, and they proved that there was cancer in the right tonsil. In this case, there was a little bit of asymmetry, not much different than this case, nothing on CT, but all the biopsies were negative. So this is just lymphoid asymmetry. And this patient had a little something in the nasopharynx, really nothing in the mucosa at all to point to, and yet they still found a tongue-based cancer in the operating room. So sometimes PET CT helps, and sometimes it doesn't. Now, there are a few adverse indicators. Cases, most patients with HPV-associated cancer will do well, but there are adverse prognostic indicators, and one of them is smoking. These patients tend to present with a higher T stage and a greater likelihood of recurrence, distant metastasis, second primaries, and death from their disease. And they may have distant metastasis at presentation. Imaging findings include matted nodes, and solid as opposed to cystic nodes are adverse prognostic indicators. And there are other adverse indicators that are not really as well known just yet. These are two examples, different patients with matted nodes, that is more than two nodes glommed together with no intervening boundary or fat planes, and this probably suggests extracapsular extension. So that's matted nodes. This is a patient who presented with throat discomfort for 5 months, and according to the clinician, looked amazingly good. Notice that his nodes are largely non-cystic. They're necrotic, but they're not cystic. There's probably a lateral retropharyngeal node, may or not be an adverse indicator. But this person actually had some pain in his shoulder region, and he had distant metastasis to bone at presentation. Now, even though prognosis is good in oropharyngeal cancer, and it should be noted that even if a patient has distant metastasis, if it's an HPV-related cancer, their prognosis will typically be better. And this slide shows survival in oral cavity and laryngeal cancer. The survival is flat, but oropharyngeal cancers due to HPV generally do better, except that every now and then there will be a patient who we don't necessarily understand who just has a relentlessly bad case. And these are very disturbing. This was a 45-year-old woman with no prior history, had a sore throat, and by the time she sought medical attention, the diagnosis of this node was poorly differentiated cancer. She had no drug or smoking history, and she's got a large tonsil cancer here that's HPV positive. Now, after chemoradiation, she had a little bit of sort of residual sulcus enhancement here, but a post-treatment PET CT, which has a very high negative predictive value, was negative. There was nothing. It was a complete metabolic response. However, follow-up imaging, just regarded this area of fullness as nonspecific, but really, it's kind of full looking, and really just unfortunately, this patient had a massive recurrence. All of this enhancement here is tumor going down into the hypopharynx and even infiltrating the thyroid gland. This is awful, massive tumor recurrence, and all of it was hot on PET, and there was distant disease in the mediastinum. So to conclude, HPV is increasing as an etiologic factor in oropharyngeal cancer. The profile of these patients, unlike mucosal cancers of a prior era, is different, with mostly middle or late middle-aged men of higher socioeconomic status. And since the majority of these patients now that we see are HPV positive, we have to address the issue of the increasing issue of T0 and positive NECs and searching for the primary. Recognition of adverse prognostic imaging features or clinical features, and considering PET-CT to find an unexpected DM or distant metastasis in high-risk patients. But despite these certain outliers, most of these patients have a pretty good response to therapy and do fairly well.
I'd like to thank Tabby Kennedy and the organizing committee for inviting you here to speak today. So in the next few minutes, we will review the anatomy and spaces of the oral cavity, and we're going to focus our discussion on a few subsites and discuss the common pathology in those subsites. So to review, the oral cavity contains the hard palate and the mucosa covering the hard palate, the alveolar process of the maxilla and mandible, the oral tongue, including the root of the tongue and the lingual septum, the buccal vestibule, and the lips. And in the interest of time, we're going to focus our discussion today on the hard palate, the oral tongue, and adjacent spaces. So the spaces surrounding the oral cavity include the buccal space that's invested on its medial surface by the buccal mucosa, the inferiorly located sublingual space, the posteriorly and inferiorly located submandibular space, and posteriorly the oral pharynx. So the oral cavity is covered with mucosa, which is composed of stratified squamous epithelium, and it includes the buccal and lingual mucosa, the mucosa covering the alveolar gingiva, the mucosa covering the dorsum, lateral and ventral aspects of the oral tongue, the floor of mouth, and the hard palate. So here's a look of normal mucosa. Here we see on the buccal mucosa, on the inner aspect of the cheek, the hard palate, the alveolar gingiva, and of course the mucosa covering the normal oral tongue, the ventral surface of the oral tongue, and the floor of the mouth. And really, when clinicians are examining the oral cavity, they can see superficial lesions very well. What they're looking for from us is to determine the deep extent of these superficial lesions, and that's going to be the theme of our discussion today. So processes involving the mucosa of the oral cavity, of course, are predominantly going to include inflammatory, infectious etiologies or neoplastic etiologies. So if we take a look at the hard palate, we see here in our normal osseous structures of the hard palate, it is composed of the palatine process of the maxilla and posteriorly by the horizontal process of the palatine bone. Our incisive canal is located anteriorly. And what I really want to draw your attention to are the foramina for the greater and lesser palatine nerves. So this is going to be important when we discuss extent of disease, particularly malignant neoplasms, where we look for perineural extension along the greater and lesser palatine nerves. Here's a look at normal mucosa of the hard palate. This is normal mucosa composed of stratified squamous epithelium. But what I want you to understand is on the deep surface of this mucosa are multiple salivary glands. So these are monosalivary glands invested within this mucosa and from which arise mostly malignant neoplasms. And we'll take a look at several examples of this. So to look at our normal anatomy here, our axial T1 weighted image here, our normal palatal bone here, this normal hypointense T1 signal of the palatine process of the maxilla, the horizontal process of the palatine bone, our incisive canal anteriorly, and our greater palatine and lesser palatine nerve foramina here, and of course the normal mucosa. The coronal plane is really the ideal plane to examine the hard palate. Here we see the normal mucosal covering on our coronal T1 weighted image, the normal marrow signal of the hard palate deep to this. And really what we want to look for, again, in case of potential neoplastic process, is extension to the greater palatine nerve foramina. On our coronal contrast enhanced CT, we see normal mucosal covering, a little bit of fat just submucosally to that. And then, of course, we see this little V-shaped notch posterolaterally. That is the foramen for the greater palatine nerve. And that is really what we want to interrogate in cases of suspected neoplastic disease. So just a couple of looks at two different patients presenting with identical complaints of pain in the mouth. And our indication for imaging is to rule out a palatal mass. So patient one, we see this mass on the anterior aspect of the hard palate. Notice the mucosa is intact around it. The mucosa around it also looks intact without inflammatory change. Very similar appearance from this patient, just located more posteriorly. So if we look at imaging from patient one and our contrast-enhanced axial CT, we see this rim-enhancing hypoattenuating mass in the hard palate. You see the nice pushing borders back here. On the bone windows, we don't see, although we're just a little bit below, but we don't see anything that indicates that it's extending to the greater palatine nerve foramina. We see this extending submucosally into the hard palate. Again, they really can't see the full extent of this. And we see, if we look carefully, that we have a mass extending really on the buccal surface of the mucosa. So there's a buccal extension as well. And we see on the bone windows that we have dental disease involving this premolar. So we have apical rarefying osteitis giving rise to this mass, which of course is a palatal abscess. Our second patient, if we look on our contrast-enhanced axial CT, we see this heterogeneously enhancing, really partially cystic, multicystic mass in the hard palate. We see that even though I'm showing you soft tissue windows here, we don't see extension into the greater palatine nerve foramen. It's just extending back. See the pushing borders here? So just pushing into the soft palate here. So this is certainly something that's a mass. We don't have any dental infection to indicate an infectious etiology. And in fact, this is a benign mixed tumor. So in many cases, as we see in this patient, there's no surface alteration. These are typically well circumscribed masses that we will see. Typically with this appearance, it can be heterogeneous, but oftentimes will enhance more predominantly with more delayed post-contrast imaging. So malignant neoplasms of the hard palate typically are either squamous cell carcinoma. Less commonly, these do arise from those minor salivary glands that we discussed. They typically do present as an ulcerated mass, which can be firm and indurated. The adenoid cystic carcinomas or other malignant minor salivary gland neoplasms, however, can be deceptively benign in their clinical appearance, and that's when imaging really becomes important to identify the etiology. In this patient with a squamous cell carcinoma of the hard palate, we see this enhancing mass extending from the hard palate onto the soft palate. When we look at the bone windows, we see that there is sclerosis around this greater palatine nerve foramen. Now, it's not widened and it's not eroded, but there's asymmetric sclerosis, so we really need to take a careful look at that. And indeed, when we look in the coronal post-contrast images, we see tumor extending up into the greater palatine nerve foramina in this patient with perineural spread. Really, it's important to always look for perineural spread in these hard palate lesions. In this patient with adenoid cystic carcinoma, we see this diffuse marrow replacement of the hard palate on our axial T1 weighted image. We see this diffuse T2 hypointense and enhancing lesion here on our post-contrast images. Notice this is extending into the greater palatine nerve foramina and to the pterygopalatine fossa posteriorly into the oral pharynx. And on our coronal post-contrast, we see perineural spread here to the Vidian canal in this patient with adenoid cystic carcinoma. Now let's turn our attention to the oral tongue. The oral tongue really consists of the anterior 2/3 of the tongue. It is composed of both intrinsic tongue muscles as well as the extrinsic tongue muscles, and those include the paloglossus muscle, the styloglossus muscle, this orthogonally oriented hyloglossus muscle, and the genioglossus muscle, which forms really the base of the tongue, or the body of the tongue, rather. So when we take a closer look at our tongue musculature, we see in our axial T1 weighted image here the normal T1 intensity of our intrinsic tongue muscles, which we see more superiorly here, the normal T1 intensity of our genioglossus muscle here, and our lingual septum, which contains fat in the root of the tongue. Again, looking at our normal tongue musculature on our axial T1 weighted image, we have the paired genioglossus muscles with that lingual septum in the midline here, the more posterolaterally and somewhat comma-shaped hyoglossus muscle, again, running in an orthogonal orientation. So these are extrinsic tongue muscles. What we see laterally to this is the mylohyoid muscle. And that's not an extrinsic tongue muscle, and that forms the floor of the mouth, as we'll see later. On the coronal T1 weighted MR image, again, we see our paired genioglossus muscles and the lingual septum in between. Inferior to this is the geniohyoid muscle. This is not an extrinsic tongue muscle, but nevertheless is inferior to the genioglossus muscles. And of course, our lateral mylohyoid forming our sling of the floor of the mouth, and inferior to this, the anterior belly of the digastric. Now, there are a number of pathologic processes that involve the oral tongue. Most of these are actually neoplastic arising from the surface that we'll talk about briefly, but in terms of benign lesions, because that lingual septum does have fat, as well as some of the intrinsic fat around the intrinsic tongue muscles, around the fascicles, we can see lipomas arising in the oral tongue as we see in this multicystic hypoattenuating mass. Notice it has the same density as a subcutaneous fat. These will rarely degenerate into liposarcomas, but when they do, it typically is those lesions arising within the oral tongue. Now, I like to just show you this to remind ourselves of the anatomy of the intrinsic tongue muscles. This is from a publication we did with Van Wadine years ago at MGH. This is a bovine tongue where we did diffusion tensor imaging. And really what I want to show you is the different colors represent the different directions of the intrinsic tongue muscles. We have our longitudinal tongue muscles, vertical and transverse. So these are all in different orthogonal directions to each other on normal imaging. This is a normal contrast enhanced CT on our axial and coronal planes. This normal stippled appearance of the intrinsic tongue muscles, nor is the normal architecture and dimension of the genioglossus extrinsic tongue muscle. Now let's contrast to this patient who has amyloid. Now amyloid is obviously a very rare disease entity in the oral cavity, but what I want you to notice is diffuse enlargement of all of the tongue muscles, both the intrinsic muscles as well as the extrinsic genioglossus muscle and geniohyoid. And really what you see very nicely here on the sagittal reform mass is that diffuse replacement and effacement of that normal architecture of the intrinsic tongue muscles. The other thing to keep in mind, of course, is degeneration atrophy that will result in a change in architectural appearance of the intrinsic and extrinsic tongue muscles, where we see in this patient on the contrast enhanced CT that we have this fatty replacement of the entire right hemi-tongue. We see prolapse of the base of tongue. Similarly, on our contrast enhanced axial T1 weighted MR, we see fatty replacement of this entire right hemi-tongue. Notice it matches the subcutaneous fat. And what distinguishes this from other processes is that we see that the fatty replacement really stops at midline. So this is just degeneration atrophy from involvement of that right hypoglossal nerve that really just stops at the midline. Oral tongue carcinoma is one of the more common things that we'll see involving the oral tongue that's going to come to imaging. These are squamous cell carcinomas predominantly, and they typically occur on the lateral and ventrolateral surfaces of the oral tongue. So in these two different patients with oral tongue squamous cell carcinoma, what we see is an enhancing mass, as we see on this coronal post-contrast CT, extending from the surface of the tongue, so the ventral and lateral aspects of the oral tongue extending into these intrinsic tongue muscles. And really what we want to identify is the deep extension. So here we see that it does not extend into the genioglossus muscle. Now, we don't any longer use this for staging, but this is going to become important in terms of our surgical planning. We'll talk about that in just a few moments. We see that there's, even though we're not showing bone windows, no erosion of the mandible. In this patient, we see a much larger lesion that's involving the whole hemi-tongue, the ventral and lateral surfaces of the tongue, through the floor of the mouth, into the opposite hemi-tongue. We see a little bit of bone erosion and extension back into the base of tongue. This is a T4 lesion. Now, what does become important in terms of understanding our extrinsic tongue muscle anatomy is for surgical planning of glossectomies in patients with malignant neoplasms of the oral tongue. And really what our surgeons are interested in knowing is whether or not there's preservation of the hypoglossal nerve. Now, how do we find that on imaging? Well, we can find it by identifying this triangle that exists between the more medially oriented hyoglossus muscle and our more laterally located mylohyoid muscle, right? So the mylohyoid muscle is not an extrinsic tongue muscle, the hyoglossus muscle is, but these form a triangle, and within that sits the lingual nerve and hypoglossal nerve, and that's what our surgeons need to know. So we need to identify our medially oriented hyoglossus muscle and laterally oriented mylohyoid muscle running from its attachment at the mandible, forming this little triangle that we see here. We can see this also in the axial plane here. And the submandibular duct is going to run through that. And we'll show that in just a second. In our coronal T1 weighted MR, we can see this very nicely. Our more medial genioglossus muscle here, and then more laterally our hyoglossus and our mylohyoid muscle, forming this little triangle as we see here in real life. You can see this is much thinner than what the diagram shows on our axial T2 weighted image here. Our medial hyoglossus muscle here, our mylohyoid muscle here, our submandibular duct coming over. This is where that nerve is running into. We need to look for that little triangle. Let's look at some examples in this patient with T3 oral tongue squamous cell carcinoma. We see this enhancing mass on the ventrolateral aspect of the oral tongue. Does this involve the hyoglossus? Well, let's look on the coronal plane. We see our hyoglossus here, our mylohyoid on the normal side. Here's our enhancing mass. It really doesn't involve this neural bundle here. So in this patient, the hypoglossal nerve rather can be spared. In a different patient, also with a T3 oral tongue squamous cell carcinoma, a large enhancing mass that we see extending ventrolaterally along the oral tongue. When we look on the coronal plane, however, in this case, that hyoglossus muscle and mylohyoid muscle are involved, and in this case, the hypoglossal nerve must be sacrificed. So as we mentioned before, as we said, the monosalivary glands invest all of the mucosa of the oral cavity. In the oral tongue, they're predominantly found in the tip of the tongue and along the posterior third of the tongue, giving rise to carcinomas, as we see in this patient. On our axial post-contrast CT and coronal post-contrast CT is what we see, this what looks to be almost like a rim-enhancing mass. But notice where this is located. This is really within the deep of the tongue at the junction of the intrinsic tongue muscles and posteriorly the genioglossus, as we see here. But notice it just has fingers extending to the surface. This is not arising from the surface of the tongue. That is squamous cell typically. What is arising within the depths of the tongue? So this should make us consider other etiologies. In this case, this was an adenoid cystic carcinoma. In another patient, a different patient, this patient was imaged over the course of a year, always with brain imaging, because the patient presented with bilateral cranial nerve 12 neuropathies, and the brain was completely normal. But what we failed to realize, unfortunately, was that there was this mass obliterating the normal tongue architecture. We can see this on our sagittal T1 SPGR image extending through the tongue, and we see this on the coronal post-contrast images. Unfortunately, this was missed on brain imaging, and we see a year later that we have this large enhancing mass extending through the base of tongue and into the oral tongue. This is a patient with adenoid cystic carcinoma. The take-home point from this is when you have a patient presenting with hypoglossal or lingual nerve neuropathies, if the brain and the base of skull are normal, you really need to interrogate the oral cavity. So now let's finish up our discussion today with a more in-depth discussion of the floor of the mouth and the sublingual space. So the floor of the mouth, as we see here, normal mucosa of the ventral surface of the oral tongue. Here's our lingual frenulum that attaches the tongue to the anterior floor of the mouth, the normal mucosa of the floor of the mouth. So the floor of the mouth is actually formed by the mylohyoid muscle as it runs from its medial attachment on the surface of the mandible underneath, supporting the entire oral cavity. Okay, so this is going to divide the sublingual space from the submandibular space. So this does communicate posteriorly, allowing this communication between the sublingual and submandibular space. Most of the neoplastic processes, or most of the processes for which we will image patients for, will include malignant neoplasm of the floor of the mouth, as we see at this squamous cell carcinoma here. And really what our clinicians are looking for is not to identify the lesion. They can see this very clearly clinically, but they're looking for deep extension into the ventral surface of the oral tongue, posteriorly through the floor of the mouth or into the mandible and beyond. In this patient with squamous cell carcinoma of the floor of the mouth, we see this enhancing mass in the floor of the mouth and involving the sublingual space extending across. And what I want you to notice here is the dilatation of this submandibular duct, meaning that there's something obstructing it, and in this case, it's a mass involving the floor of the mouth. Now, you can see that because it's extending along this duct, we would need to look for involvement of the hyoglossus muscle here. We also want to look for invasion of bone. In this case, the bone of the lingual aspect of the mandible is intact. And on our coronal post-contrast images, we see extension across the midline, and we're looking for involvement of the genioglossus, which is involved in this patient. So our sublingual space is bounded laterally by the lingual aspect of the mandible, as we see in our axial T1 weighted MR image here. It is bounded medially by our genioglossus muscle and geniohyoid muscles, and it is bounded also in the medial aspect by our hyoglossus muscle. So our sublingual gland sits in the middle here in our sublingual space. It is bounded posteriorly by our submandibular space, as we see here. Now, what it's important to understand is the sublingual space is not encapsulated by fascia and is actually anteriorly continuous under that frenulum that we showed earlier. So our sublingual space, of course, contains the sublingual gland, as we see here on our axial T2 weighted image here, our hyperintense sublingual gland. It also contains the deep lobe or the uncinate lobe of our submandibular gland, from whence arises the submandibular duct, which also, again, the hypoglossal nerve, and the lingual nerve are going to run along on the lateral aspect here of our hyoglossus muscle. as we see very nicely on our T2 wetted image. In terms of pathologic processes that involve the sublingual space, commonly what we will see is the ranula, which is basically a mucus retention cyst arising from the sublingual gland and sits within the sublingual space. As we see in this clinical photograph here, they tend to have this sort of bluish appearance. They typically arise secondary to trauma, or in the pediatric population, it's typically from an imperforate duct. These are true cysts arising in the sublingual space. And as we see on the axial post-contrast CT image here, we have this rim-enhancing, well-defined cystic mass. You see it's on the posterior aspect of our sublingual gland. It is bounded posteriorly by our mylohyoid muscle, so it is entirely within the sublingual space. It's pushing up medially against that genioglossus muscle. And we see that it is uniformly hypoattenuating. Sometimes you'll see a thin rim of enhancement around the castle, but typically this is not enhancing. This is a classic ranula. Now, these can sometimes extend into the submandibular space, in which case they are called a plunging ranula. As we see, we will see a thin tail of the cyst in the sublingual space that extends over the mylohyoid muscle into the submandibular space. And we see that very nicely in this patient with this uniform cystic mass in the sublingual space. You see this necking down as it's coming over the mylohyoid into the submandibular space. We see that beautifully here on the sagittal reformat as it comes over that mylohyoid into the submandibular space in this patient with a plunging ranula. And lastly, we will also see dermoids and epidermoids in the sublingual space. Again, as you all remember, these are congenital epithelial inclusion cysts. Dermoids, of course, will contain fat, as we see beautifully in this old axial contrast enhanced CT image, where we see this large cystic mass in the sublingual space, and we see lots of flat globules in here, of course, consistent with classic dermoid. And that wraps up our discussion of the oral cavity and common pathologic processes, and I thank you for your attention.
Hi, I'm Amy Giuliano. I'm a head and neck radiologist at Massachusetts Eye and Ear Infirmary in Boston, Massachusetts. And I want to thank Tabby Kennedy for the opportunity to speak. My topic is larynx and hypopharynx. So first, let's start with the larynx. I will talk about the subsites, spaces, and cartilage. So the subsites are supraglottis, the glottis, and subglottis. So the supraglottis is separated from the glottis by the laryngeal ventricle, and more specifically, the apex or the most lateral edge of the laryngeal ventricle. The glottis is separated from the subglottis basically by 1 centimeter. So you draw a line from the top of the true cord, or the apex of the ventricle, which is very similar. You go down caudally for 1 centimeter. At the end of that starts the subglottis. And the subglottis ends at the bottom of the cricoid cartilage, which is the end of the larynx. Here is a video from a laryngoscopy showing these recesses on either side, and those are the laryngeal ventricles. And here is a histology specimen, MRI, and the specimen itself showing the ventricle, which are these recesses off to either side. Above the ventricles are the false cords, and below the ventricles are the true cords. The ventricle is a key landmark in description of larynx, especially in the context of cancer, because it divides the subsites supraglottis from glottis, which are different in terms of staging. And also, if you have a tumor at the ventricle, it can grow laterally into spaces, upstaging tumors, as we will discuss later. The true cords are just below the laryngeal ventricle, and on this laryngoscopy, the true cords form this inverted V shape. And the true cord or true vocal fold is composed mostly, the bulk of it is a muscle called the thyroarytenoid muscle in blue. The medial part of this is called the vocalis muscle. And at the very edge of it, at the vibrating surface, that is the vocal ligament, which is depicted in yellow. This vocal ligament goes anteriorly and inserts into the thyroid cartilage at the point known as the anterior commissure. And here the vocal ligament is called Broyles ligament. Broyles ligament goes right into the thyroid cartilage where there is no perichondrium. So here's an axial CT image showing the level of the true cord. And you can see at the level of the anterior commissure, there's usually hardly any soft tissue at all. The vocal ligament inserts to the base of the arytenoid cartilage. So when we see the cricoarytenoid joint, both cartilages on the same image, you know you're at the level of the vocal ligament or the true cord. Because there is no perichondrium at the anterior commissure, it's a weak point, an access point for tumor to go right into the cartilage. So for example, here we actually see a very small tumor at the anterior commissure, but it has grown and invaded right into the cartilage and beyond into the strap muscles. When we image the larynx, it's very important that we do so during quiet respiration, because that's when the true chords will be a little bit away from each other, so we can actually see the surfaces of the true chords, so we can see tumors such as this. We can tell there's exophytic soft tissue coming off of the left true chord, and that there's thickening of the anterior commissure. How do we tell where we are in the larynx on an axial CT? Well, here are the landmark images. On top, we can see there is fat, and when we see fat, we know we're at the level of the false chords, and that would be the supraglottic larynx. When the fat goes away, and we start seeing both the arytenoid cartilage and the cricoid cartilage, we know we're at the insertion of the buccal ligament, which is the level of the true chord, and here's the anterior commissure, which is very thin. And then when it opens up to an oval, and we see much more of the cricoid cartilage, we're at the subglottis. So the landmarks are paraglottic fat, telling us it's supraglottic, arytenoids along with cricoid, telling us we're at the glottis, and the cricoid ring telling us we're at the subglottis. Now at the subglottic level, there should be hardly any soft tissue between the air in the lumen and the cricoid cartilage. So if there's any thickening at all, that would be abnormal. It could be tumor, it could be granulation tissue, but that is abnormal. Because we rely on these landmarks when we interpret larynx imaging, we have to make sure that our axials are always controlled and normalized to a certain plane, which is the plane of the true chords. So we always have to reconstruct our axials, no matter how the patient was positioned in the scanner, such that our axials are parallel to the plane of the true chords. Spaces. There are two important ones. One is the pre-epiglottic space, which is this area that contains fat. It's demarcated from above it the hyoepiglottic ligament forming the roof, the thyrohyoid membrane, and the thyroepiglottic ligament, or the petiole, which is the root of the epiglottis. Here's a sagittal MR showing this area that's fat-filled, that is the pre-epiglottic space. And in this patient with a tumor involving the lingual surface of the epiglottis, it has invaded past into the pre-epiglottic space, so the fat is now effaced. The second important space to know is the paraglottic space, which is everything that is lateral to these two yellow lines on this coronal drawing. This yellow line up top at the supraglottic level is called the quadrangular membrane, and this other yellow line at the glottic and subglottic level is called the conus elasticus. Now you can't see these lines, these structures on CT or MR, but know that they're there, and know that whenever there's anything lateral to them, such as in this CT here in this patient, that is in the paraglottic space. So this was a patient with a tumor that started in the laryngeal ventricle and grew laterally and invaded into the paraglottic space and then also into the epiglottis. Involvement of the pre-epiglottic space or paraglottic space upstages a tumor to at least T3. So that's an important finding to note. The hyoepiglottic ligament is right there, connecting between the hyoid and the epiglottis, right there, forming the roof of the pre-epiglottic space. Here is a sagittal MR on this specimen showing the hyoid bone, and here's the hyoepiglottic ligament, forming the roof of the fat in the pre-epiglottic space. The hyoepiglottic ligament is a barrier preventing tumor from going from the pre-epiglottic space of the larynx upwards towards the base of tongue. The thyrohyoid membrane is this sheet that goes between the thyroid cartilage and the hyoid bone. The very back of it is called the thyrohyoid ligament. And here we can see two different patients, one with a laryngocele, one with a saccular cyst, or fluid-filled laryngocele. This air-filled laryngocele has gone through the thyrohyoid membrane, whereas the saccular cyst here is confined by the thyrohyoid membrane. In both cases, we need to make sure we check the level of the ventricle, that there is not a mass there obstructing the ventricle, because sometimes these things can form as a result of blockage. So there's a ball valve phenomenon, and fluid secreted, air entrapped in there cannot escape. And indeed, The patient with a saccular cyst here did turn out to have a tumor that is obstructing at the level of the ventricle. Here's another patient with a tumor that has gone into the paraglottic space, but not only that, it has invaded past the thyrohyoid membrane out to the strap muscle, so now this is at least a T4A tumor. The cricothyroid membrane is this membrane right here between the cricoid cartilage and the thyroid cartilage, and that is a weak point where a tumor can go through. So here are two different patients with subglottic tumors that had gone through the cricothyroid membrane anteriorly out towards extralaryngeal location. The epiglottis is flexible. It can deflect and close the larynx when we swallow so we don't aspirate. There is a suprahyoid and an infrahyoid portion, and the infrahyoid portion is perforated with a lot of holes. And those are weak points where tumors can then go from one surface of the epiglottis to the other. Here's a patient with a larynx tumor that grew up along the laryngeal surface of the epiglottis, up to the free edge of the epiglottis, crawled around to the front and up towards the base of tongue. Because of these perforations, this tumor can also go anteriorly through the perforations and invade into the pre-epiglottic space. This is just a slide to show you 6 different patients of different ages, 3 years old, 59, in their 60s and 70s, with different patterns of ossification and calcification of laryngeal cartilages. There's no rhyme or reason. These patients are all normal with no larynx cancers. You can see that some areas are completely sclerotic. This 74-year-old has hardly any areas of the thyroid cartilage ossified at all, just the posterior tips. So the take home is that the ossification process and pattern very variable and often asymmetric, which makes it hard for us when there's a larynx cancer to decide whether there is tumor invasion into the cartilage sometimes. And that is why MR comes in very handy. So here's a patient who has had both CT and MRI. You can see on the CT, portions are ossified, portions are not ossified. And now how do they look on MRI? Well, on both T1 and T2, the non-ossified cartilages are intermediate to low signal. The ossified cartilage behaves basically like bone. So there's a hypointense rim, and the middle basically follows fat signal because it's fatty marrow, and it would suppress on fat suppression. We should not see enhancement inside the cartilage. So anytime there is enhancement in the medullary cavity, we have to suspect tumor, especially if it is isointense to an adjacent tumor. So for example, here's a patient with a larynx cancer, thickening of the anterior commissure, bilateral true cords, and then what about the thyroid cartilage? Well, we look on the MRI, and we can see bright on T1 at the back, that's fatty marrow. Very dark on both T2 and T1, that's going to be normal cartilage. And then otherwise, everything in between could be tumor or reactive change, and that's where we go on to post-GAD. And in fact, when it enhances a lot, oftentimes that signals inflammatory change, edema, reactive change, and that's actually okay. It's the stuff that is kind of intermediate, the evil gray, especially when it is isointense to the adjacent tumor. So this is going to be tumor invading into the thyroid cartilage. Another helpful tool is dual energy CT. We take advantage of the different energy levels and we look at the behavior. So for example, here we can see on 40 keV, very dense material that at a higher keVs go out. And that follows along iodine, which is taken up by tumor. So this stuff is tumor. Whereas, so that's the yellow line. Whereas for the pink, that follows the line for cartilage. So it's actually quite dense later on at the higher energy levels. So we know that that is not tumor taking up iodine that has dropped out, but staying dense at 140 keV, and that is cartilage. All right, hypopharynx. The subsites of the hypopharynx are 3 of them: piriform sinuses, post-cricoid region, and the posterior hypopharyngeal wall. So here's an axial CT showing the piriform sinuses, back edge of the aryepiglottic folds, and the lateral wall. And the posterior hypopharyngeal wall is the back wall. A little bit lower down, here, right behind the cricoid, forming the anterior wall of the lumen, is the post-cricoid hypopharynx, whereas forming the posterior wall of the hypopharynx is the posterior hypopharyngeal wall. Let's look at a few different sample cases, and I have put in green boxes the important structures that help with staging. So let's look at this first case. Clearly, there's a big enhancing mass that's involving the piriform sinus, right? Back surface of the AE fold, the lateral wall, so that's all piriform sinus, but also the posterior hypopharyngeal wall, and probably also the post-cricoid region. There's invasion of the thyroid cartilage, which means this puts it into at least a T4A category and out towards the strap muscle, T4A, and there are also abnormal metastatic nodes. Here's another patient. We can see lower down now. There's involvement of the post-cricoid region, which is the anterior wall of the lumen at the level of the cricoid cartilage, as well as the posterior hypopharyngeal wall. Here's another case. We can see involvement of the piriform sinus, posterior hypopharyngeal wall, probably the post-cricoid pharynx as well, and this is infiltrating all the way out towards invading into the thyroid cartilage, out to the strap muscles, and even bulging backwards towards, but maybe not beyond the fascia and not quite into the prevertebral space. Now here's case 4. That's a similar case. It's kind of a companion case, but a bit different. So again, very bulky. Maybe the posterior hypopharyngeal wall, right? But I want to distinguish this case from the one earlier, which is here in this yellow box, where this yellow box, the case we saw earlier, the laryngeal structures are staying put. But case 4, everything is pushed forward. And in fact, you can maybe see this muscle that is bulged anteriorly by this mass. So this mass turned out to be in the retropharyngeal space. So in fact, this was a retropharyngeal sarcoma and not a hypopharyngeal carcinoma. So in summary, this was a whirlwind tour. Know your anatomy, know the structures that are important for cancer discussion, the subsites, barriers to tumor spread, and weak links to tumor spread. Thank you very much.